inshallah, we'll start soon. Okay, someone has started the recording. That's good. So I'll share my screen. Just a second. Okay, can you see my screen now? Can you hear me, please? Hello?
Yes, doctor.
Okay, can you see my screen, please?
Yes.
Okay, lovely. So we'll start. Just give me 1 second to join from the mobile phone as well, so that if someone will join us, I can admit him or her. Okay, so we'll start the collection of retina cases that we see in our everyday work. So let's say that we have got 2 patients. One of them has been diabetic for 25 years, and his fasting blood sugar is 110 milligram per deciliter. So he has a controlled blood sugar. And the second one has got diabetes for only 1 year, and his blood sugar is not very well controlled. Which one is at more risk of developing diabetic retinopathy? What do you think?
The first one.
The one who is not controlled but for shorter duration.
Any other opinions?
The first one.
The first
The first one.
Basically, we should know that the duration of diabetes is more relevant to the development of diabetic retinopathy than the actual control of diabetes at the moment. Of course, the diabetic control is important, and poor control accelerates the changes. But if I have 2 patients, I would be more concerned about the one with long history of diabetes. By the way, if a patient is diagnosed with type 1 diabetes, when he or she should have his first eye examination? Immediately after diagnosis or a bit later on?
Type 2.
If there's a patient with type 1, what? Okay. If there's a patient
immediately.
Immediately.
Type 1? No, type 1, they should have the screening usually at puberty, which is about 4 to 5 years after the diagnosis. But in type 2, they should have the first examination as soon as they are diagnosed with diabetes, because type 1 usually it has an abrupt onset. So the patient, we know that he started to suffer diabetes from the time of the start of the symptoms and the start of the treatment. But in type 2, the patient may have been suffering subclinical diabetes for several years before the diagnosis. So by the time the diagnosis is made that he or she is diabetic, there may be some diabetic changes that are present already. Is that clear for you?
Yes.
Yes.
Okay, so can you tell me about other risk factors for diabetic retinopathy? What are the risk factors that you should, ask the patient about or think about them when you are assessing a patient for diabetic retinopathy, other than the duration of the diabetes and the diabetic control?
ممكن pregnancy.
Pregnancy. What else? That's true.
Hypertension.
Hypertension. Okay.
Hyperlipidemia.
Okay. Blood pressure. So we have what's this patient doing? He's having a
Renal failure.
Renal failure, and he's having renal dialysis. This is usually nephropathy and retinopathy. They are both microangiopathy, and the presence of poor kidney function is an additional risk for the development or progression of diabetic retinopathy. And pregnancy. Usually, if there is a pregnant lady, how frequent should she have her diabetic screening during the pregnancy? I'll say that she should have the diabetic screening probably every month during the pregnancy. And what the risk of progression to proliferative diabetic retinopathy accelerates very much during the pregnancy. This is why if there is a patient with, let's say, mild or moderate non-proliferative, she should be under close observation, because in 1 or 2 months she may progress to proliferative diabetic retinopathy. Okay, so if we see a patient like this, how are we going to comment if you are faced with a photo like that and you are asked to comment on that? How we are going to comment on that?
A colored photo of the right eye.
Brilliant. So we need first to say whether it's a colored photo, it's a red-free photo, or it's a fundus fluorescein angiogram. And then we need to see which side, right or left. How can we know that this is the right eye, please? Indeed, it's the right eye, but how can we know that?
The disc is on the right, on the nasal side.
Exactly. So this is the nasal side. The nose is supposed to be here. So this is the right eye of the patient, and the left eye is on the other side. Okay. So it's whenever you're faced with a photo like that, you don't need to give the final diagnosis. Just buy some time, get yourself some more time to think. Just start to talk that this is a colored photo. It's of the right eye. What can you see? What are the signs that you can see here? Let's take them one by one. If we will focus on those small reddish dots, this one and that one, can you see my my pointer?
Yes.
Yes.
Okay. What are those reddish lesions here?
Microaneurysm.
I'll say those are microaneurysms. Usually the dot and blot hemorrhage are a bit larger than this. Of course, they may be dot hemorrhages, and the only way to differentiate is by doing fluorescein angiography. What will be the difference? If they are microaneurysms, will they be hyperfluorescent or hypofluorescent? Hyperfluorescent. And on the contrary, if they are hemorrhages, they will be hypofluorescent because of the blood fluorescence. So I'll say that those are microaneurysm. What's this one?
Hemorrhage.
What type of hemorrhage? We have two types of hemorrhage here. What's the difference between this one and that one? What's the name of that one first?
Blood hemorrhage.
This is a dot, or actually a blot hemorrhage. It's slightly larger than the dot hemorrhage. Okay, so I'll say probably this is a dot hemorrhage, but this one, those are blot hemorrhages. Okay, and what is the name of that one?
Flame-shaped
This is a flame-shaped hemorrhage. What's the pathological difference between this one and that one, according to the location in the layers of the retina? Which one is deeper? Deeper means towards the choroid, and which one is more superficial towards the vitreous?
Flame hemorrhage.
Flame-shaped is superficial.
Is in the nerve fiber layer, so it takes the distribution of the nerve fiber layer. It's more superficial, and the blood hemorrhage or dot hemorrhage, those are usually in the outer plexiform layer and nuclear layer, so it's more in the deeper retina. Okay, brilliant. So let's move on. What's the difference between this and that one? Which one is a cotton wool spot and which one is a hard exudate? What is that?
Hard exudate.
A hard exudate. And this one is?
Cotton wool spots.
What's the difference in the appearance between them? Why would you say that this is a hard exudate rather than a soft exudate? It's usually yellowish in color. This is grayish white in color. It's usually smaller in size. This one is larger in size. It has a very well-defined border, so you can track the border of that with a pencil or a pen. But here it has a more diffused border. Okay? What is the difference of the histopathology in between them? This one, what is it made of? What is the hard exudate made of? It's lipoproteins. So usually there is an area of leakage, and there is deposition of the proteins, and it's the lipoproteins. They are deposited and give this hard exudate. While the soft exudate, what are they? The pathophysiology of them?
Infection
Anyone can answer?
Of fibers.
Usually there is a swelling of the nerve fiber layer due to stasis of the exoplasmic flow, and this indicates ischemia. Okay? Okay. What else? We have some venous changes here. If you notice here, the vein is a bit dilated and a bit, what's called, there's a bit of early venous bleeding. Again, this is a sign of ischemia. And we have here what we call the venous looping. You can see a loop of the vein here. It's called the venous looping. And here we have probably some erymas, some abnormal connection between the artery and the vein, but we don't have frank neovascularization of the disc or frank neovascularization elsewhere. So what will be your diagnosis about this case? Is it a retinal vein occlusion? Is it diabetic? Is it age-related macular degeneration? What's the big category?
Diabetic.
Why will you say diabetic? I agree with you, but why? Because there are some microaneurysms. Microaneurysms are the hallmark of diabetic retinopathy. They are not present in retinal vein occlusion if it's not associated with diabetic retinopathy. So I'll say this is a diabetic retinopathy. Which class of the severity of the diabetic retinopathy? Is it non-proliferative or proliferative? What do you think?
Non-proliferative, severe non-proliferative.
I'll say that I agree that this is severe non-proliferative. Why would you say that it's a severe non-proliferative, please? What are the criteria of severe non-proliferative?
Irma venous bleeding.
Yeah, so we have what's the rule? What's the name of the rule? The 4-2-1 rule. Have you heard about that? So if you have multiple retinal hemorrhages in all 4 quadrants, this is the 4 part of the rule. 2 quadrants with venous changes, venous bleeding and looping, or Irma in 1 quadrant. So this is called the 4-2-1 rule. Okay? So this is a patient with severe non-proliferative diabetic retinopathy. And what else? What about this?
Diabetic macular edema.
Exactly. And there is macular leakage, macular edema, or leakage diabetic maculopathy. Call it whatever you want. But you should classify 2 things: the peripheral changes, the ischemic changes, and then you should comment if there is macular edema or not. What are the types of diabetic macular edema? It can be one of 3 types. Either leakage maculopathy, characterized by thickening and hard exudate, or ischemic maculopathy. Usually it is characterized by, in the colored photo, you cannot diagnose the ischemic maculopathy in the colored photo, except if there is, silver wiring of the macular vessels, which is not very common. But how can we diagnose it? Unexplained visual loss of or diminution of the vision of the patient. So you see there's nothing wrong with the ocular media clarity or the macula. The macula looks fine, but the patient cannot see very well. So mostly there is an element of ischemic maculopathy. If you do fluorescein angiography, what will you find in ischemic maculopathy?
Extension of the fuzz.
Exactly. So there is an enlargement of the foveal avascular zone. And in the OCT, what is expected to be found? You find thinning of the macula rather than thickening of the macula in leakage macula. Okay? So who can comment on this one? Any volunteer?
Fluorescein angiography of the right eye.
Of the right eye. Is it an early phase of the angiogram or late phase of the angiogram? Can you comment on the phase of the angiogram from what you see here?
Late phase.
Late phase. What do you think about this one? What is this sign called? Can you see? This is the vein. This is the artery, and this is the vein. It's called the early laminar flow. So you find that the dye is, going by the walls of the vein, but still not filling the vein completely. This one probably was filled, and if you will wait a few seconds, you'll find that this one will fill exactly like that one. But I can tell from this one that this is an early or a late phase of the angiogram.
Early.
It's an early venous phase. Okay. What can I see in this? Usually, whenever I'm commenting on the fluorescein angiogram, I use the terms hyperfluorescent and hypofluorescent. So what can you say about this starry appearance, as if there are many stars there? What are those stars? Those are hyperfluorescent. What?
Microaneurysm.
Exactly. So those are hyperfluorescent microaneurysm. And what about this one? Is it hyperfluorescent or hypofluorescent? Hypofluorescent. What do you expect the cause of that will be?
Hemorrhage.
Exactly, which causes blocked fluorescence. So whenever we have hypofluorescence, think about either blocked fluorescence like that one, or insufficient perfusion like this area. If you see this area, you find what we call a capillary dropout. So the capillary filling is okay on all over these areas. We have this nice grayish background, but here you find that it's dark and it's not filling properly, and we have some abnormal vessels at the edges here. So this is an area of capillary dropout. And what's your comment about the fuzz here? The fuzz should be something like this. Here we notice it's extending beyond it. So there is an enlargement of the fuzz, which indicates that there is an element of what?
Ischemic maculopathy.
Ischemic. So I'll say that this patient mostly is having the third type of maculopathy, which is mixed. So there is an element of leakage from those microaneurysms. And if you will take serial images and go to the late phase of the angiogram, you will find that those microaneurysms are leaky. And how can we diagnose the leakage in the microaneurysm? How does it look like when you compare the early angiogram and the late angiogram? It increases in what and what? In size and in intensity.
And intensity.
Exactly. So you find that it starts with a point of leakage here, and in the late phase of the angiogram, you find that it enlarges in size and in intensity with ill-defined borders. Okay. So again, what's the diagnosis of this patient or this eye? Is it diabetic? Is it retinal vein occlusion? Is it age-related macular degeneration? What do you think?
Diabetic retinopathy.
So which type of diabetic retinopathy?
Non-proliferative diabetic retinopathy.
Severe non-proliferative.
I'll say probably non-proliferative. I'm not sure whether it's severe or not severe. You cannot judge from here. The 421 usually goes for the colored photograph. Okay, but here it's either when you have extensive hemorrhages or you have ERMA. Here I cannot find an ERMA. Okay, or if there is venous changes. But up till now in this one, I can't say it's severe. I say it's non-proliferative diabetic retinopathy. So this patient have this abnormal vessels here. Who can give me a comment on this one? Anyone would like to comment?
The color, The photo of right eye, right fundus.
Excellent. Showing. What's this one? Let's take them one by one. What's the one just up to the pointer here, just above the pointer? This small reddish dot. And this one. And that one. Those are microaneurysms. I'll say microaneurysms or small dot hemorrhages. I cannot differentiate. But what's striking here? Here again, we have some. What are those yellowish spots here?
are the exudate.
Are the exudates? What about this area?
Cotton wool spot.
Cotton wool spot. And if we look carefully here, what can we say here? What can we see here?
New vessel.
Those are new vessels of the
disc.
So according to the location, we classify them either new vessels of the disc, like this one, or this one is called. What's this one called? This is another patient. The blood vessels, abnormal vessels, are growing away from the disc, and they are called
NVEs.
NVEs, new vessels elsewhere. So what do you think the treatment for this patient should be?
BRP.
Or how, if I'll say, how will you manage this patient? What type of investigation you may need for this patient first? Do you think that there's something wrong here?
Macular hole?
Yes.
I will not say it's a macular hole, but there is some sort of abnormality here. I'm not sure what this is. How can I assess this better? What type of investigation?
OCT?
OCT. Let's say if the patient has diabetic macular edema, what will be your plan for treatment of this patient? So the patient has diabetic macular edema on the OCT and NVDs like that.
anti-VEGF.
BRB?
Okay, I heard someone saying anti-VEGF and I heard someone saying PRP. Both of them are correct, but how can we arrange them? Which one should we start first?
Anti-VEGF.
So we start with injection. The injection will hit two birds with one stone. So it will decrease the diabetic macular edema, and it will cause some regression of those new vessels, which allows you to do more laser, better laser treatment. Because sometimes if there are lots of hemorrhages, you cannot do proper laser treatment, and you may need to raise the power of the laser. But when the patient is treated with anti-VEGF first, it causes some regression, which enables you to treat them better. Okay. So who can comment on this one?
دكتور الBRB يتعامل بعد الانتي فيجف بقد ايه؟
There's no convention about that. مفيش اتفاق على الموضوع ده، لكن most practitioners will give the anti-VEGF followed probably 1 or 2 weeks later with PRP, with the start of the PRP treatment, and they may need to repeat the anti-VEGF later on to treat the diabetic macular edema. Usually the diabetic macular edema is treated with more than a single injection. So we start one of the injections, 1 or 2 of the injections before the laser, and then we do the laser, the remaining injections after completing of the laser. Okay?
Okay.
Who can comment on this one?
Fluorescein angiography of the right eye?
This is not the right eye. Sorry. This is the nasal retina. This is not the macula. The macula is on that side. Okay? The nasal blood vessels are coming like that, so it's a bit tricky. So it's the left eye. And what can you see in this angiogram? Again, start one by one. What are those starry things?
Microaneurysm.
So I can say there are many hyperfluorescent microaneurysms. There are some. What about this area of blocked fluorescence? Can you see it underneath the cursor here? And this one. So there are blocked areas like this one again. Blocked areas corresponding to blocked fluorescent due to retinal hemorrhages. And what about this hypofluorescent area? Can you see this extensive hypofluorescent areas? This area, there is a good capillary perfusion, but if you compare all that area, there is loss of the capillary bed. So there is an element of ischemia or capillary dropout.
Okay.
You agree with me?
Yes.
Yes.
Okay. And then what are those starry things that come in the middle of that dark night?
NVEs.
So we have NVDs and then NVEs. And why do they leak like that? Why they appear leaky like that? Leaky means if you take photo in the early phase, so this is taken 2 minutes, 3 seconds after the injection of the dye. If you take it probably, let's say 20 seconds after the injection of the dye, you'll find just few blood vessels, but without this leakage. But as we go later in the angiogram, we find this leakage. Who can explain why do we have this leakage?
Because they are abnormal vessels.
Those abnormal vessels, they lack the blood retinal barrier. So there is what we call the tight junction in between the endothelium, which is present in the normal capillary blood vessels. But in those NVDs and NVEs, they are leaky because they lack this tight adhesion between the endothelial cells. So they tend to leak. Okay? So how are we going to treat this patient?
BRP.
Again, PRP, okay? So this patient had a successful pan-retinal photocoagulation treatment. What's the rationale of having the pan-retinal photocoagulation? Why do we do the PRP? What's the pathomechanism by which the PRP treats the proliferative diabetic retinopathy? What happens when we do the laser treatment? So when we do the laser treatment, we ablate the peripheral ischemic retina. So we stop it from producing vascular endothelial growth factor. And thus, we lower the intraocular level of the vascular endothelial growth factor, which is responsible for the new vessels formation. So by treating the ischemic retina, you cause regression of those new vessels. You got the idea? So we don't go and treat those new vessels directly. We treat the peripheral ischemic retina, and subsequently this causes indirect regression of the new vessels. Is that clear for you? Okay. When we do the treatment, we treat the peripheral retina and we don't come closer to the macula. We are aiming at preserving the macula without laser treatment and without complications. Okay? What are the consequences if we will not treat those patients? What's wrong with this eye?
Probuse iris, new vessel in the iris.
So we have new vessels of the iris with subsequent neovascular glaucoma formation. Okay?
Yeah.
So the vascular endothelial growth factor will start to diffuse anteriorly and causes this. And whenever you are faced with a patient who presents, for example, with a vitreous hemorrhage, and you know the patient is diabetic, before putting dilating drops, one of the good things to do is to look at the fundus, because the patient will come and say, "Doctor, I'm diabetic. I've not been on follow-up for years and years and years. And a few days ago, I had, for example, some constipation or a cough or something like this, and I lost vision in my right eye." So you start to think this patient most probably had a retinal bleed, something like this, a vitreous hemorrhage or a retinal hemorrhage, and I'm going to dilate him to check what's going on. Before you put the dilation, look for those new vessels, because if they are present, this indicates that the condition is very, very advanced, and you may want to act very quickly. Okay? What is going on here? What's wrong with this patient? What's this complication?
Retinal attachment. Retinal attachment.
Which type of retinal detachment?
Tractional.
So there is a traction here. Traction. The new vessels elsewhere will start to proliferate and cause some fibrous proliferation. Here, there is an element of tractional retinal attachment involving the macula, so it's pulling on the macula. Okay, and as you can see, within the glial tissue, you can see the abnormal new vessels there. Okay, so there is another bunch of new vessels here, and there is a third one here, and there are a fourth one here. So how are we going to treat this patient?
First, vitrectomy to remove the traction.
We need to do vitrectomy, delamination, to remove the vitreous and remove the traction and relieve the traction so that the retina will come flat again. Can we do laser treatment?
No.
Theoretically, you can do laser treatment. It will stabilize the vision, but the risk that the vision will, continue to drop because of the traction is still there. So in some areas of the world, if they don't have access to vitreoretinal surgery to do vitrectomy, doing a laser treatment is better than doing nothing. Okay, but of course, if there is an element of traction, it's always better to go for vitrectomy delamination. Okay, so here this patient have what we call a pre-retinal hemorrhage and vitreous hemorrhage. He or she has both of them. So here is the disc, here is the macula. This is a pre-retinal hemorrhage. So the pre-retinal hemorrhage accumulates in the potential space between the back surface of the vitreous and the front surface of the retina. And it usually gives this boat-shaped appearance of this fluid level. If the blood will break through the posterior hyaloid face and goes inside the vitreous cavity itself, it's called the vitreous hemorrhage, like that one. So sometimes patients may present with pre-retinal hemorrhage, and sometimes patients may present with vitreous hemorrhage which become diffuse all over, and you cannot see the details of the retina. Okay? So let's move to this patient. This patient complained of recent diminution of vision. He's diabetic, and when you examined him, you find this appearance. Who can comment on this appearance?
I colored the photo of the right eye.
Of the right eye, it shows multiple
hard exit.
a ring of hard exit. What is in the center of this hard exit? Those things above my pointer, those two red dots and this one.
Blood hemorrhage.
Actually, they are leaking microaneurysms. Okay, so what's going on here? That those leaky microaneurysms are causing some leakage. This leakage, if you look, you'll find that the retina is thickened in that area either by examination or by the OCT. You find that the retina is thickened, and then at the edges of that thickening, the lipoproteins will start to settle down and give this what we call ring shape or sarsenet shape hard exit. Okay, and if you look at this OCT of this patient, you will find that what is this sign called?
Cystoid macular edema.
Cystoid macular edema or intraretinal fluid, and we have what's that? It's called neuro. It's not RPE detachment; it's neurosensory detachment. So this is the RPE.
Subretinal fluid.
Yeah.
Subretinal fluid or neurosensory detachment. Okay, and we have the hard exudate, which appears as hyperreflective intraretinal structures at the edge of the thickened area. So here and there, corresponding to the cut here and there. Okay, so how will you treat this patient?
By anti-VEGF.
So we need to do repeated anti-VEGF injections. Some doctors will say, well, the leaky points are away from the fovea, so we may go for focal laser treatment of those leaky microaneurysms. But again, this is declining now. Most of the practitioners now will go for repeated anti-VEGF injections because usually it's more effective. Okay, will we need to go for a single injection or multiple injections?
Multiple injection.
So usually those patients will not respond to a single injection, and we may need to do multiple injections. Okay. If you do fluorescein of this patient, you may find
the hyperreflective.
Sorry?
Sorry, the hyperreflective lesions on the OCT, what are those?
Those are the hyperreflective hard exudates. So when the scan is passing through here, you'll find that in the middle there is thickening and hyporeflective cystoid spaces of the intraretinal and the subretinal fluid. And at the edges, when the scan is scanning this area, you find that there is a hyperreflective intraretinal structure corresponding to this hard exudate. Okay? Okay, brilliant. So if we do a fluorescein of this patient, who can comment on this fluorescein?
Fluorescein and geography of the left eye.
Okay.
The phase is probably late phase.
Again, I'll say mostly it's an early phase.
Early
look at the vein here. Still, it's not very well filled.
Yeah, there's laminar flow of the vein is early phase.
Okay, so it's an early phase, and it shows. What's that? This is the second type of leakage of diabetic maculopathy. So we have the leakage type, and this is the ischemic type. As you can see, the phase is large and irregular here, and there is shortage of the blood flow to all of that area in the macula and even outside the macula. If you look clinically at that patient, you'll find mostly that the arteries here are silver wired. So they are, rather than being nice and red like that, you'll find that they are white in color, which indicates that there is no blood flow to that part of the retina. And usually this patient will have poor vision, and unfortunately there is no way that you can improve this vision if it's pure ischemic maculopathy. Usually they will not benefit of injections. If they are mixed ischemic and leakage maculopathy, they are expected to benefit a bit, but the prognosis is, is not brilliant. So this is why it's important to do fluorescein angiogram for patients like those, just to see if there is an element of ischemia or not. Okay.
Okay.
So what's that?
Injection of anti-VEGF.
Intravitreal injection. We cannot tell if it's anti-VEGF or whatever, but probably because it's a clear fluid here, I'll say it's an anti-VEGF. How can we do the intravitreal injection? What's the technique? So what is the distance at which we do the injection?
It depends, is it a phakic or pseudo-phakic?
If the patient is phakic,
3.5?
4 millimeters.
I'll say 3.5 to 4 millimeters. If the patient is aphakic or pseudophakic, I'll stick to the 3.5. Okay. What is the risk if we do the injection closer to the limbus?
Can hit the lens and cause cataract.
Cataract.
You may hit the lens and cause cataract, or you may hit the pars plicata and cause bleeding. So usually this area corresponds to the pars plana. This is the least vascular area that can give us access to the posterior segment. This is why we prefer it. What if we will do the injection further back?
Going to get into the retina and the choroid.
We can cause a retinal hole or a retinal tear and cause retinal, which can proceed to retinal detachment. Brilliant. Let me ask you, what are the potential, when you are consenting a patient about doing intravitreal injection, what kind of risks that you should discuss with him or her?
Some increase in intraocular pressure.
Mm-hmm.
We might cause a retinal tear.
Okay, so when I'm talking to a patient that I'm going to inject, I'll say, okay, why? I'll explain first that we are doing the injection because this drug, if given as drops, it will not reach in sufficient concentration to the back of the eye. And then you may want to tell him or her that according to the situation, if you are injecting for a retinal vein occlusion or diabetic macular edema, you should clarify that you may need to go for several injections. And usually we leave an interval of 4 weeks at least in between each 2 injections, because the drug will remain active for that period of time. You should mention to him or to her the possible risks. The most dreadful one is the endophthalmitis, and you should mention that there may be some risk of bleeding, whether it's subconjunctival bleeding or bleeding inside the eye. There are the risks of hitting the crystalline lens causing cataract, or hitting the retina and causing retinal tear or retinal detachment. Those are the potential risks. And again, there is the risk of failure of the treatment. So if you are treating a patient for diabetic macular edema, he or she may have the injections and may not respond very well. Okay? Good. Let's move on to another patient. This patient have this appearance. He presented to you in the in the night shift, complaining of sudden diminution of the vision in that eye. You look at the fundus and you see this appearance. Can anyone give a comment on this fundus photo?
Cherry red spot.
The cherry, it's a fundus photo of the right eye. It shows a cherry red spot. And what else?
Pale retina. Pale fundus.
It's pale retina. Yeah, it's grayish white pale retina. And what else here? What's your comment about those arteries? Are they filling normally? Very attenuated flow in the retinal arteries. Okay, so your diagnosis will be
Retina chain.
central retinal
Artery.
artery occlusion. Can anyone explain to us why do we have this cherry red spot? Why does it appear?
Because of lack retinal nerve fiber at the macula.
So where is this reddish color coming from? Is it from the retinal circulation or from where?
The choroid. It's a
Choroid, yeah.
reflective choroid.
It's the choroid.
That's
Actually, what
high
happens that
pigment.
when we have this central retinal artery occlusion, the retina will become edematous. Nerve fiber layer and the retina itself will become edematous. The fovea is the thinnest area of the retina, so it will not be that that edematous and that opaque. And this is why the underlying color of the choroid can still be seen through the retina. And actually, it's the color of the choroid. So the contrast is because the retina is becoming more pale in color rather than this part becoming more dark. No, this part is the same. It's the same color like the normal eye. But because this part is becoming paler, it gives this appearance of the cherry red spot. Okay? So what's your comment about this fluorescein? Who can comment on this fluorescein? How can we comment on that? I'll say it's a fluorescein angiogram of the right eye. Is it the right eye?
Left eye.
It's the color, the fluorescein of the left eye, and it shows what draws your attention here. Delayed filling of the arteries, usually described as prolonged arm retina circulation time. Have you heard about that term before, arm retina circulation time?
No.
So it's the interval between when you inject the dye in the antecubital vein in the patient's forearm and the time till the dye starts to appear in the retinal circulation or in the angiogram. And usually it's estimated to be something like 11 or 12 seconds. So it's the time that needs to circulate through the veins back to the heart and to be pushed in the arterial system to go through the carotid arteries to the central retina, to the choroidal and the central retinal artery. Usually in patients with central retinal artery occlusion, they have what we call a prolonged arm retina circulation time. So it takes longer for the dye to appear in the retinal and the choroidal in the retinal circulation, not the choroidal circulation. Okay. So you have a patient like that coming to you in the night shift. What should you do to him or to her?
Orbital massage.
Okay. So usually is it a thrombotic or an embolic origin?
Embolic.
Embolic. In the retinal artery occlusion, it's usually due to an embolism. In contrast, the retinal vein occlusion is usually thrombotic in nature. So our aim is to try to dislodge the embolus to a smaller branch of the retinal artery, to convert it from a central retinal artery occlusion into a branch retinal artery occlusion. So we do what we call the ocular massage. This is useful. Yeah. What else? We try to lower the intraocular pressure so that the blood and the embolus can pass to a smaller artery. So we can do paracentesis, we can do give intravenous mannitol or Sidamex or something like this in order to try to lower the intraocular pressure. We can ask the patient to breathe in a bag, or give what we call the carbogen, because the carbon dioxide causes relaxation of the arteries, which can help in dislodging the embolus to a smaller branch. Then, after the acute event is over, what should we do? Should we let the patient go home peacefully, or we should do something else?
We should.
We should do what?
Refer the patient to physician.
Ask the patient we need to look for the source of the embolus. Usually there is a source of the embolus. So what kind of investigation should we do to check for the source of the embolus?
Echocardiography.
And so usually we ask, usually echocardiography, I agree if there is vegetations on one of the valves of the heart, or a myxoma in the heart or something like this. But there is something more common to cause this
Carotids.
Carotid. So
Carotid
what type of
Doppler.
investigation should we go for?
Ultrasound.
Carotid Doppler. It's called the carotid Doppler to see if there is an atheromatous plaque in the carotid, which causes dislodgement of calcium or cholesterol emboli. Okay, this is very, very important. Okay, what about this patient? Who can give a comment on this patient? There's something here. Can you see it?
Yeah.
So
Yes.
sometimes you have a patient referred to you for an ocular examination, and they think that the patient is having a central retinal artery occlusion, or a patient is having transient visual loss, and he or she is referred by the internal medicine department for an ocular check. They know that they have this transient ischemic attack, and they know that they there is usually an embolic thing. They are waiting for you for something very important that you should put and include in your report. You should look very carefully and report if you can see an embolus or not. And if there is an embolus, just give them a clue what's the type of that embolus. There are 3 important types of emboli. Do you know them? Cholesterol emboli, platelet fibrin emboli, and calcium emboli. And usually each of them draws the attention to certain pathology. So calcific emboli, usually it goes with a calcific, calcific atheromatous plaque. Cholesterol emboli, this one is a calcific embolus. For example, it's usually chalky white in color and small in size like this one. Okay? There are cholesterol emboli. They are a bit longer and not very white like this. Those usually, if you tell them that I can find a cholesterol embolus, they will think that this patient mostly has an atheromatous plaque and look for it. Okay? And if the patient has a platelet fibrin emboli, they should investigate if he has hypercoagulability or something like this that causes this emboli to occur. So they will wait for you to tell them if you see emboli or not and what's the type of those emboli. Here we have very similar appearance to the central retinal artery occlusion, but it's taking only sector of the retina. And what type of visual complaint will this patient have?
Scotoma.
He will have scotoma, or what we call an
Scotoma.
altitudinal field defect. So the patient will come and say,
I didn't ask.
there is a loss of sector of my visual field. I can see through that sector, but for this one, for example, you say it's in the upper part of the field because it's affecting the lower retina. Okay, and if you do the fluorescein for that patient, you'll find that there is poor perfusion of a sector of the retina, and you can tell that the occlusion occurred at this part. So all the sector supplied by that part of the artery is not very well perfused. Okay. This patient again has ischemia. Both of them in fluorescein angiogram, both of them have ischemia. But what's the difference? What's the diagnosis in this patient?
CRV.
He has an element of an ischemic central retinal vein occlusion because there is extensive areas of ischemia. Why should I not say that this patient is diabetic? I don't think this patient is diabetic. Why?
Because there are no hyperaneurysms.
There are no microaneurysms.
Microaneurysms.
Just the venous changes, just the capillary dropout, but there are no microaneurysms. Okay, and I'll say, can you say whether this patient has ischemic or non-ischemic central retinal vein occlusion? What do you think?
It's ischemic.
I'll say that this patient has ischemic central retinal vein occlusion. Why would you say this?
Because more than 10 disc area.
Exactly. If you have a larger field of the fluorescein, you'll find that there are extensive areas of capillary dropouts. Okay. And again here, do you expect the vision to be poor, very poor, or very, very poor? What do you think?
Very, very poor.
It's extremely poor here because there is very poor perfusion of the macular area. So the patient Usually, patients like this will have a vision of hand motion or PL. What are the risks of untreated condition? If you leave this patient untreated or unattended, what are the possible risks that may happen to him or to her? What is the most important thing?
Neovascular glaucoma.
Neovascular glaucoma.
Neovascular glaucoma, or what we call the 100 days glaucoma. Okay, if the patient will start to develop neovascularization, what is the most common site for this patient to develop the neovascularization? Is it neovascularization of the disc, neovascularization elsewhere, or neovascularization of the iris?
Of the iris.
Always remember, in patients with ischemic central retinal vein occlusion, they are more prone to neovascularization of the iris because the retina is damaged and new vessels cannot grow on damaged retina. So the vascular endothelial growth factor will diffuse anteriorly and cause its effect anteriorly. While in ischemic branch retinal vein occlusion, you have sometimes an ischemic branch retinal vein occlusion. Which type of neovascularization is more common in branch retinal vein occlusion?
Elsewhere.
Exactly. And they usually present with vitreous hemorrhage. They can present with vitreous hemorrhage. So they usually, the new vessels start to develop at the junction between the avascular retina or ischemic retina and the vascular retina. Okay. So this is an example of a branch retinal vein occlusion. I cannot be 100% sure whether it's ischemic or not from this appearance, but I'll say that there are many hemorrhages. They are not so extensive. Sometimes it can be more extensive, and I'm sure it's ischemic. Here, I'll say I'll need to check the patient's vision. I may need to do fluorescein to check if it's extensive hemorrhage or not. Note that the more common type of hemorrhages, of retinal hemorrhages in retinal vein occlusion is the, what's that type of hemorrhage? Nerve fiber layer hemorrhage, or the flame-shaped hemorrhage. Blot and dot hemorrhage do appear, but they are more common in diabetics, while in retinal vein occlusion, nerve fiber layer, or what we call the flame-shaped hemorrhages are more common. Okay, I think this is enough for today. We have another meeting that we will arrange probably in 10 days or something like this. I'll let you know about the next date. If someone can download the lecture, please do and share it with the colleagues. Inshallah, in the next time, we will keep on, doing it the same way, in this practical way, how we think about the patients, how we manage the patients, etc., etc. Do you have any questions now?
Regarding this photo, is there anything at the macula?
Yeah, of course, there is something with the macula here. The hemorrhages are, it's called abutting the macula or invading the macula. And if you will do an OCT of this patient, I'll say mostly you'll find that this area, the lower part of the macula, at least close to the fovea and in the whole macula, there is a cystoid macular edema, I'll say. Mostly this patient will have cystoid macular edema, and mostly he or she will need to have an intravitreal injection of anti-VEGFs to resolve this edema. He or she will need follow-up to see if he or she will have ischemic changes and neovascularization elsewhere. And if there is neovascularization elsewhere, how can we treat it?
Sector.
What we call the sector pan-retinal photocoagulation. So we do pan-retinal photocoagulation, not to the whole retina, but just to one sector of the to the retina. Okay. Any other questions? Any other concerns? Okay.
Thank you.
You're welcome. If you have any questions, just try to write them down and ask me next time. And hopefully, inshallah, next time we will discuss more cases. Okay. Good night. Take care.
Thank you, doctor.
You're welcome.
Good night.
Assalamu alaikum.